All right. Well, thank you guys for coming today. For last week we had the kickoff of our spring or fall semester of the Ultrasound lecture series, and Bob kind of gave us a little bit of a preview as to the coming attractions, and we got some exciting topics for this fall that's lined up. So looking forward to that. But like I said, today we are kicking off a little mini series on the FAST exam. It'll be over the next at least 3 weeks. We may have a fourth week just talking about some literature updates about the FAST. But we're going to divide the FAST evenly up into kind of the categories that it really neatly divides into, the belly, the heart, the lungs, and discuss kind of the implications thereof and how to do it. So that being said, let's dive right in. So as we get started, I like to paint pictures to kind of help you have this mental image in your mind of kind of what we're talking about, right? And some patients that we could anticipate using this on, so that we can understand the exam a little bit more. So imagine yourself working a trauma shift, and it's you run into you have a 35-year-old female status post rollover MVA with these vital signs. So pressures are not horrible for a 35-year-old, maybe a touch on the soft side. Definitely tachycardic. Respirators are going pretty good. Her lungs seem to be working pretty well. She's not hypoxic, but she is altered and she is agitated. So imagine that patient coming in. Or this one, a 23-year-old dude that got pinged somewhere, got shot. You find a penetrating wound to the left chest and the right lower abdomen, and the vitals are such. Really hypotensive, really tachycardic. Again, the lungs seem to be working pretty decent. Or a 35-year-old female falling with reasonable vitals. Okay, and said, "Hey, I was walking along and tripped over my dog dish. Kind of banged my left chest on the way down." So what do you do? What's your next step? I mean, obviously it's FAST, right? You're in the FAST lecture. Okay. Have you guys ever seen these guys? Seen this TV show? John? Yeah. So this is one of my favorite TV shows. Yes, I'm weird, because I like old school stuff. Johnny and Roy, and Dr. Brackett, Dixie McCall, and Joe Early. So this is a show that was on in the 70s. It's called Emergency. It's actually a really good show. It's everything I like about emergency medicine. It's the two paramedics, two docs who run the ER, obviously the nurse in the ER. So, in your spare time, take a look at the show. But this, basically, this represents the birth of emergency medicine, right? So these guys are actually surgeons, and this is kind of where our roots came from, okay? But I put this up to say, hey, back in the 70s, there wasn't a lot codified in terms of how we manage trauma. In fact, when you watch them, their trauma care is very different than what we do here. Granted, it's TV. But there's a lot of clinical diagnosis, there's a lot of plain film diagnosis, and now if you go to our trauma bays, we're seeing, we see the patient, whatever, I don't care what they say, we'll just put them in the scanner and see what the donut of truth shows. So lots changed, okay? And a lot of that comes, as a result of, this event here. So there's a family, there's an orthopedic surgeon and his family. We're flying back home, they live in Nebraska, right? I think they're going from New Mexico or somewhere in the Southwest. But they're flying home in a small little single-engine plane, private pilot. And on February 17th, 1976, they crashed. All right? So this is the guy's name. Jim Steiner is his name. He's an orthopedic surgeon. That's his airplane. Okay? Believe it or not, he survived. Okay? He had a rib fracture, zygomatic fracture. His wife, unfortunately, did not share the same fate. She was ejected from the plane when it impacted. She was killed. They had several children on board. Their son Christopher, he survived. He had a right forearm fracture and a hand laceration. Richard, 8, had a head injury and was unresponsive. Randall, 7, had a head injury and was unresponsive. And Kimberly, 3, again, head injury and was unresponsive. This happened in the middle of nowhere, right? So they're out in rural Nebraska, okay, and they show up at the local ER and the doors are closed. Okay, they can't get in. As a result of what happened here, it really kind of caused a bunch of surgeons to say, you know what, we don't really have a great unified way of dealing with trauma care kind of in the rural settings. If you get shot and roll into an academic medical center, fine, you're pretty decent. But when you roll into these rural centers, we don't really have a great way of taking care of you. the education hasn't really rolled out that far. Actually, interesting, if you want to read a historical perspective on trauma care, read the book Rawhide Down by Del Quinton Wilbur. It's the story of when Reagan was shot, and kind of details his ER and OR time. I think it was GW. But anyway, out in the rural setting is totally different, okay? And so that caused a bunch of surgeons to develop what we call ATLS, or Advanced Trauma Life Support. And I'm sure we've all heard of this. Most of us have gone through the course, and the rest of us who haven't yet will do so, assuming you guys are going to go into emergency medicine, right? So anyway, out of that sprung out ATLS, which is basically a unified approach to how we approach a trauma patient, much like ACLS, BLS, PALS, etc. The goal is to educate and treat trauma patients in a unified manner, whether it be rural areas or in the urban areas, okay? And that's really because, of this, okay? Trauma is a big killer, all right? This is the latest statistics that's available on the CDC as of this morning. So their 2016 report with data from 2015. They're usually a couple of years behind in the data they present. But look at this. Unintentional injuries is the 4th leading killer in the United States of all people, behind heart disease, cancer, and lower respiratory diseases, so pneumonias, right? And actually, back in 1980, okay, it was still the 4th leading cause of death, okay? So it's something that kills a lot of folks annually. And if you look at the demographics, it's obviously it's high up there. And for young folks between, I think it was the age of 15 and 40 something, it's one of the leading causes of death, right? And 10% of people who suffer trauma actually have a lethal outcome. Okay, so 90% survive, but even still, you get hurt, you have a 10% mortality. That's pretty significant. Okay, and 2/3 of the folks who suffer thoracic trauma die after they reach the hospital. Okay, this is from the Journal of Emergency Trauma and Shock in 2008 study that was published then. So it's a significant impact, that we have on our patients. All right. And for those of us who've done trauma, we've seen this trimodal, graph, right? So there's a cohort of people that just, they're dead at the scene. There's absolutely nothing that we as ER docs can do about it, right? Brain injuries, brain stem injuries, aortic injuries, they're just so massive that, we can't do anything, okay? There's a lot of, things that happen late in the game, okay? Sepsis, lung injuries, things like that. Again, on the front end, there's some things we can do to kind of prep the patient for the best shot, but really, infections from complications of, their care, it's not a ton that we can do about it, at least in the emergency department. So what we're worried about is kind of this middle cohort, okay? The folks that come in alive to the ED, they're injured, and they have injuries that, if not identified and managed, are going to lead to bad outcomes, okay? So that's what we want to. That's what we want to try to identify, and that's what hopefully our workup is going to be able to uncover. Okay. So this is done in a pretty systematic way, right? Again, this shouldn't be necessarily groundbreaking or earth-shattering information. But you've gone through ATLS, you'll see this, and if you see the way we roll in the trauma bay, you can kind of see how this works. But basically, we have a primary survey, which is basically assessing for immediately life-threatening things that are going to kill you in the next 5 minutes. Okay, so we can imagine these: airway obstruction, not breathing, tension physiology, whether it be tension pneumo, pericardial tamponade, massive exsanguination, things like that. Okay, that's the primary survey. A, B, C, D, E: airway, breathing, circulation, disability, exposure. Okay, and that's generally followed by what we call the secondary survey, which is just a systematic, usually stem to stern, evaluation for injuries to help guide and direct what testing we need to do further. Okay, so that's where, hey, pupils equal and round, extract motions intact, midface stable, nasal septal hematoma, tracheus, midline, heart and lungs sound fine, belly and chest are non-tender, pelvis stable, etc., etc. Okay, so that's the secondary survey. All right. Now there's adjuncts to each of these. Okay, so we always see the chest X-ray and the pelvis X-ray being done in the trauma bay, and it almost gets done reflexively. Okay, there's been some progress in not having to reflexively get all the plain film imaging in the end. But really, if you look at the ATLS guidelines, right, chest X-ray and the pelvis X-ray in the trauma bay are supposed to be adjuncts to the primary survey. So hey, is there a concern for a pneumo that we can't detect clinically? Is there, concern for a open book pelvic fracture? I heard you guys talking about, open book you guys had recently. An open book pelvic fracture is going to cause massive bleeding that we need to identify and bind, or, from a less lethal but still, highly morbid, condition, like a hip dislocation. There's a hip that we need to get in before we kind of, go rolling through the scanner. So things that we need to identify early and intervene upon early, those are adjuncts to the primary survey, right? And then traditionally, the kind of the workup at the end of the secondary survey is your CT scan, your comprehensive plain film X-rays, looking for extremity or long bone fractures, your laboratory evaluation, fill in the blank, whatever other things you want to do to identify then all the injuries in order to manage said injuries. Okay. So the question really comes, we're sitting here in an ultrasound lecture. Where in the world does ultrasound fit into this? Okay, this is a pretty well established, if you read through ATLS guidelines, that's going to be what you're going to find. Okay, primary survey, your adjunct. Secondary survey, your workup. Okay, so what about ultrasound? Well, ultrasound first showed up in the evaluation of trauma folks in the 1970s. Okay, so basically there's an article where they documented the detection of a splenic hematoma in the 70s. But there wasn't a lot of activity until really the mid-90s, okay? When this study was published, it was basically ultrasound performed by surgeons to assess for injuries in these trauma folks, okay? So in the mid-90s is when ultrasound really started coming in. And it's really developed since then into what we call the FAST exam, or the focused assessment with sonography and trauma, to evaluate for hemopericardium and hemoperitoneum, two major life-threatening events that we need to know about. Okay, and really, what is supplanted in the trauma workup is the DPL, the diagnostic peritoneal lavage. Okay, so back prior to ultrasound, if you're concerned about a intra-abdominal hemorrhage, DPL the patient, see if there's blood, and if there is, whoops, take them to the OR. If not, keep moving on. So the ultrasound really kind of came in and supplanted the DPL to the point where, I think I've done one in ATLS. We just don't do it in the trauma bay anymore. We now do ultrasound. So with that background in mind, this is kind of the pattern, or the outline for the next few weeks. So we're going to spend today talking about the abdominal fast and how to utilize that, where to utilize it, what we're looking for. Next week, we're going to talk about the cardiac fast, and then we'll follow that with the thoracic. You're doing thoracic, right? I think so. Does that work?
Yeah, I just can't remember when it was.
Well, we can. The order of the other two may be switched a little bit.
No, probably not.
We'll see how things work. But anyway, that's kind of the outline for the next several weeks. All right. So again, today's objectives is review the role of fast in trauma. Okay, we kind of did that a little bit. We'll talk about some more. Kind of review what the abdominal fast is, and then discuss some unique cases that you may encounter when performing the abdominal fast. Okay, and because this is a CME event for all those of us who want CME, I got to tell you that I have no disclosures to make. Though disclosures are welcome should they present an opportunity. So, anyway, the joke works every time. So, fast and trauma. What is it? Okay, so the fast is designed to evaluate, like I said, for hemoperitoneum and hemopericardium. If we keep this one fact in mind, I think we do ourselves a huge service. Because when we start kind of, wandering off the reservation, as it were, in terms of kind of indication creep for the fast, then we start getting into trouble. And when you look at it for hemopericardium and hemoperitoneum, the test performance isn't horrible. In fact, and it really depends on what article you read, right? So the test performance ranges kind of in the high range for the sensitivity, but even better for specificity. So if you see something there, you're pretty sure something's there. If you don't see something there, you can't rule out injuries. Okay, basically what this says. And, like I said, depending on what article you read, this number may be a little higher, maybe a little lower. You really have to get into the nitty-gritty of the article to understand why. But if you keep this in mind, you kind of got a rough shot there. Okay, and it's based on a few assumptions. All right, unfortunately, assumptions aren't necessarily always good, but we have to make some presuppositions, kind of get some bedrock of what we're going to accept to be true to be able to build on that. So the assumption is any important abdominal or cardiac injuries will be associated with free fluid. Now, if I had the trauma surgeons here, they'd be like, but not all injuries are associated with free fluid. Granted, okay? And this is where some of the sensitivity can suffer in the FAST exam. You're not going to find all injuries, all possible injuries, But significant injuries, vascular injuries, solid organ injuries, lacerations, hollow viscous rupture should be associated with a decent amount of free fluid. Okay, blood in these cases, GI contents in the latter. Okay, and in the setting of previously healthy patients, intra-abdominal fluid in the trauma patient is assumed to be blood. Okay, now can you have a patient who's on peritoneal dialysis, just got their diastolate put in, crash their car, and they have free fluid in the belly? Absolutely. Okay. Clinical correlation is always recommended, okay, and advised. But if you have a otherwise healthy 20-some-odd-year-old who, crashed their car and has a belly full of fluid, in all probability, statistically speaking, it's probably blood. And you should probably assume that before you kind of go down the path of just blowing it off as something else. All right? So those are some assumptions we make. What about pitfalls? Okay. The FAST tells us that there's fluid there. It doesn't tell us what that fluid is. Okay, I can say, hey, there's something in the belly, there's something around the chest, around the heart, there's something around the lungs, but I can't say this correlates with blood for sure. Okay, the radiologists, when they do the CAT scans, they can tell you the Hounsfield units and say this correlates with hemoperitoneum or this correlates with simple fluid. There's no Hounsfield units for ultrasound. Now you can describe some echogenicity in the fluid. Okay, that can give you some clues. But it is no slam dunk, okay? And the FAST will miss injuries that are not associated with free fluid. We kind of talked about this a little bit. So like any mesenteric hematomas or bowel wall injuries that doesn't cause any bleeding or content leaking, it's not going to find that, okay? Now we can also argue about the how good the CT scan is in some of those cases as well, but that's neither here nor there. Be aware that if it doesn't have free fluid, you're not going to pick it up on the FAST exam. Okay, so from that perspective, like I said, we're not going to see mesenteric injuries terribly well. We probably are not going to see solid or hollow organ injuries terribly well. Okay, and retroperitoneal injuries, since they're buried deep down behind a lot of air-filled bowel, are going to be hard to see. Now you can. There are some findings that can suggest some retroperitoneal hematomas. Bob showed an example last week. If you have a displacement of the kidney or things like that. That should raise your suspicion. But again, the FAST is generally regarded as having a lower sensitivity for the retroperitoneum. Okay. Unfortunately, a couple of years ago, an article was published, and the surgeons would like to point this one out. That basically says the FAST doesn't impact the treatment of blunt and stable trauma patients. Okay. Again, we can argue about the methods here. When doing this study, the surgeons were looking for the FAST exam compared to CT scan in identifying all injuries. Okay, and of course the FAST is going to fail miserably when we're looking for all injuries. So again, we have to keep this in mind. Okay, the FAST has its purpose, has a point to it. But if we start pushing the indication creep, then we're going to suffer in some of our sensitivities in evaluating for all injuries. Okay, so I just kind of wanted to bring this one up and show you guys this is what the counter to all of us who are ultrasound enthusiasts are going to say about the FAST. Okay, so where is the FAST indicated, right? We talked about how poorly it performs. Where do we actually need to do it, right? So when you have trauma to the torso, consider a FAST. Okay, when you have hemodynamic instability, highly indicated. Okay, we want to know why the patient's unstable. Okay, in trauma, we're assuming that the instability is blood. Okay, I mean, maybe they're septic and they were on their way to their doctor's appointment and crashed their car, and they would have been admitted to the ICU anyway. But unfortunately, just kind of had a fender bender, as possible. But if you're coming into the trauma bay, you're hemodynamically unstable, it's always assumed to be hemorrhage, first and foremost. Okay, and when you think about hemorrhage, you think about it in a couple different body cavities and what will make you unstable: in the brain, in the chest, around the heart, in the belly, in the legs, or on the floor. Okay, I guess you could say that retroperitoneum as well. But those are the main places you're going to look. And the FAST exam actually looked in a fair number of those. Brain can't do anything about that. In the ED, we're going to get a CT scan in a minute anyway. Lungs, we can look around that. That'll be week 3. Heart, we can look around that. That will be week 2. Belly, that's today. Okay. Legs, hopefully you should be able to see a big old thigh hematoma. Blood on the floor. If you can't see it on your trauma bay floor, you probably should look around. You won't be able to see it on the highway. So some of these things you're not going to be able to detect. With imaging anyway. So in this situation where they're hemodynamically unstable, it actually rules out 3 or 4 different key places where we can hide blood and cause hemodynamic instability, right? The other place that is highly indicated is in penetrating trauma. In fact, I would venture to say that this is probably your best bang for the buck for the FAST exam is when you have penetrating trauma, especially when they're unstable. But any penetrating trauma to the box, right, clavicles to belly button, nipple to nipple, essentially, needs to have, in my opinion, a FAST exam looking to see if there's a pericardial effusion, because that's the thing that's going to kill you right away. And then you can expand out from there. All right. And then the last thing, this is every time you have indications, you kind of have this vague indication, right? Any mechanism concerning for blood loss that may lead to hemodynamic instability. Okay, so it's certainly not unreasonable, and different hospitals will vary in the way they do FAST exams to just do this as a screening study. Okay, understanding that you're not going to detect all injuries and you're going to need further workup anyway. But some hospitals, all trauma patients in their primary survey, it's A, B, C, D, E, F, right? Airway, breathing, circulation, disability, exposure, FAST exam. That's certainly not an unreasonable approach, knowing that you're not going to stop at F. You're going to do your secondary survey and your imaging. So keep that in mind. There'll be times, if you scan enough, you're going to be surprised by what you find and say, "Oh, didn't expect that. This patient's got a belly full of blood. Now I need to, maybe move them up in the queue of patients that are going to get scanned." Okay. So this is a pretty reasonable algorithm, to how you think about ultrasound in the context of trauma. And this is kind of what we do here. If they're hemodynamically unstable, really get that FAST scan going. Okay, and this is pretty well supported by our trauma folks. If they're unstable, you're going to be hard pressed to find a trauma patient or trauma attending here who's going to really put up a stone wall against a FAST exam. Okay, if they're stable, this is kind of where the discussion comes. Well, is it really going to affect or change your management? Okay, and we can have that conversation. I think that'll be a good conversation to have, but that's not the point of today. And this is going to be institutionally dependent where you kind of integrate the FAST in the stable patient. All right? So let's talk about the FAST itself. We talked about when to do it. The FAST itself. There's 4 basic windows of the traditional FAST. And you guys may have been saying, well, Matt, what about the E-FAST? It's coming. That's weeks 2 and 3. 3 in particular. But there's 4 basic windows of the traditional FAST exam, right? So the most common, the right upper quadrant view, okay, left upper quadrant view, subxiphoid view, and the suprapubic view. Okay, so in the right upper quadrant view, we're looking at a few different areas, but most commonly that potential space between the liver and the kidney, what we call Morrison's pouch. Okay, but you can also find blood above the kidney, under the diaphragm. You can find it above the diaphragm in the chest. Okay. And one of the other areas that's really important to look for is looking at that right pericolic gutter. Okay, as you leave kind of the Morrison's pouch area, where the ascending colon comes up, there's a gutter that kind of guides and directs fluid down into your pelvis. And oftentimes you'll see fluid collecting in the gutter even before you'll see it kind of moving into the Morrison's pouch, depending on where your source of bleeding is from. Okay, same thing on the left, right? You have the spinal fossa, okay, that potential space, but really based on the way the ligaments in the liver, ligaments in the abdomen, are folding and kind of connecting things in the left upper quadrant. This is not your key place where you're going to collect fluid. You're actually going to collect fluid most often in the subphrenic or below the diaphragm area between the diaphragm and the spleen. So you want to look there. You want to look up into the chest and the pleural cavity, and then again in that left, pericolic gutter. Okay. We'll show pictures of some of these later. From a subxiphoid perspective, this is giving you kind of that quick look at the heart to see if there's a pericardial effusion. So underneath the xiphoid process aimed up towards the heart, you get a nice 4-chamber view of the heart with kind of liver in your forefield. And finally, the suprapubic pouch, looking to see if there's any fluid collecting in the abdominal portion of the pelvis, right? So stuff that's within the peritoneum, but kind of in the pelvic bowl. Keeping in mind that, when you scan males versus females, you're going to have extra anatomy that will affect where the peritoneal reflections are, and we'll see that in a second. All right, so the right upper quadrant window, right? We're going to look at these different places: the pleural space, the subphrenic space, the Morrison's pouch area, and the right pericolic gutter. So here's your standard right upper quadrant view with your liver, kind of that mid-range echogenic, homogeneous textured structure. Okay, it's really hard to miss. It's right there. And if you scan kind of in the midline, so a little bit behind the midline, you run into the kidney. Okay, and this is your classic view, right? So just for reference, this is superficial. This is deep. Our probe indicator is off to the left of the screen, which indicates that it's going towards the patient's head. And then by proxy, this is the patient's feet down on the opposite side. So we have a liver, we have our Morrison's pouch, and this potential space where fluid can collect and kind of displace the tube. All right, but fluid can also collect in this pleural space. Okay, so you got to keep an eye out for the diaphragm, this bright white line just above the liver. Okay, because fluid can collect right up there. Sometimes you can get fluid in the subdiaphragmatic area, less commonly in the right. Okay, and then the pericardial gutter is just beyond the liver tip here. Okay, so when I'm looking at the right upper quadrant in the trauma bay, and I have whatever trauma attending looking over my shoulder, being like, "Come on, Matt, what's the answer?" I'll be looking at Morrison's pouch, glance up at the pleural space, glance down at the gutter, and call it done. Okay, I'll usually save just a couple pictures right there. You can do that real quick. Questions about that so far?
Isn't there like a fat pad around the kidney?
Can be.
And
Can be.
what's the size of the fluid collection that we should really worry about? Any fluid is half bad?
Any fluid, I mean, obviously you need to correlate clinically. If it's a medical patient with ascites, and take that into consideration. But you shouldn't really have, in a normal adult, you shouldn't really have a ton of fluid. Now, there's some literature to say that kids can have just a teeny bit of fluid in there. And I've definitely had a few kids that I've fasted, and there's like these little drops of fluid. And it really provides a lot of consternation for the trauma attending, so they're like, great, now I've got fluid, what is it? But it's common to have just like a drop for kids. But for adults, you really shouldn't see fluid. Okay, so if you see anything between the kidney and the liver, it's abnormal. All right, so here's an example of an abnormal, right? We have this liver, okay? It's our big landmark. One of the things that I like to say in ultrasound is, use your landmarks to guide you where you need to be. So when you're taking off at Hopkins Airport, or when you're flying on life flight, and you want to try to identify your location, assuming you're not up front and have the GPS, you look down and see structures. Okay, hey, there's this hospital, there's this shopping plaza. My house is halfway between the two, so there's my house, right? You use your landmarks to guide you to where you need to be. So in this situation, use your liver. It's a big landmark. It's hard to miss, right? And you guide that to your kidney. You can see a whole bunch of echo-free or anechoic fluid kind of bathing that liver and between the liver and the kidney. So that's a positive FAST exam right there. All right. Here's one that's a little less obvious. Okay, and you have some perinephric fat like you were talking about, but you see this little wedge of anechoic fluid kind of tucked in there, kind of creeping its way into Morrison's pouch. So another positive FAST exam. Make sense? Right? Left upper quadrant, very similar. Okay, you're looking at the pleural space, the subphrenic space, the splenorenal fossa, and the left pericardial gutter. So again, I put it on there, find where I need to be, look up at the chest, look square at the spleen, look down at the gutter, and get a quick answer. And the more you kind of three-dimensionally reconstruct that organ in your mind, the better your sensitivity gets, right? If you just do it once and off, your sensitivity is pretty poor. But if you look at it, kind of look up, look down, look at it, you're kind of getting more of that wide-angle view, and you're going to be more likely to catch little bits of fluid here and there. So for the picture example here, here's our spleen. Tends to be a little smaller, tends to be a little bit more rounded than the liver. Okay, the splenorenal fossa is right here. Again, not the most common place for fluid to collect, but you certainly can have it there. The diaphragm is this hyperechoic line on the north border of the spleen. So again, here's the indicator: patient's head, patient's foot. The tip here is superficial. Kind of the base of the scan here is deep. So you can get fluid kind of between the diaphragm and the spleen, or you can get fluid in the pleural space. Okay, so there's kind of the 3 to 4 areas that you're looking at, and then I obviously tip it down and look at the gutter down here at the spleen tab. All right, so here's an example of a positive. Here's a spleen, here's a diaphragm. See how the fluid's collecting between this diaphragm and the spleen. Okay, not an uncommon view for the left upper quadrant. And here's the reason why you want to look at the gutter, right? So between the spleen and the kidney, not much. You don't really see much here. Here's a diaphragm, the spleen. You don't really see much tucking in there. Got a little ring down, so the lungs are up. There's really not a big fluid in the pleural space. But bathing this spleen tip, the south border of the spleen tip, there's just a little bit of fluid that if you just kind of glance right up here, you totally miss. Okay, so you want to angle down and look at that gutter. Make sense? Pelvic window, we're really looking at that retrovesicular space. Okay, and obviously keep in mind the pouch of Douglas for women. But here is the sagittal view of the pelvis. I like the sag view, in the pelvis. When you do transverse, it's really easy to be kind of angled too low and actually into the pelvis and out of the peritoneal space. So I like the sag view because it gives you a nice, view of kind of the peritoneal space, kind of here on the the cephalic side of things, and then the pelvic space kind of in the caudal side of things here. So again, probe indicator, head, foot. This tip here is superficial, base here is deep. We have our bladder. Again, an obvious landmark that's hard to miss when there's fluid in it. And the fluid should collect kind of in this area. Okay, so going on the superior border of the bladder. Okay, the uterus in here. So the peritoneum is going to reflect across the dome of the uterus, back here, and then kind of go back up the surface of the retroperitoneal space. So it'll be kind of on this left side of the image. You won't expect free fluid to be on the right side of the image because that's pelvic, not peritoneal space. Here's an example of a positive. You have that bladder right there. You can see the intestines are kind of displaced superiorly in the cephalad position. You can see fluid kind of interdigitating with the intestines and the bladder. Does that make sense?
And your probe is lateral?
My probe is in the midline. Yeah, so right in the midline in the sagittal or up and down orientation. And basically when I do it, I put it down, I scan from left to right so I see the whole width of the bladder, kind of be able, again, reconstruct three-dimensionally kind of what's in the pelvis to kind of evaluate for little bits of free fluid here and there. And the last part of the window is the subcostal window. And this is, again, used to evaluate for pericardial fluid. We'll talk more about the heart in the pericardial space next week. But it's certainly the part of the traditional fast, and this is used, to look for anything that's going to be hemodynamically unstable, causing tamponade physiology around the heart, right? And so we want to apply it liberally when there's any penetrating injury to the thorax. Okay, anything that has the potential to have a trajectory through the mediastinum, you really should be doing a fast exam to look for pericardial fluid or pericardial or hemopericardium. So from an imaging standpoint, again, here's the tip here. It's going to be superficial. This is going to be deep. Now we're in the subcostal area pointing up towards, up through the heart towards essentially the posterior part of the shoulders. So this is going to be anterior, kind of posterior, down to the base here. The probe indicator is again to the left. So this is going to be of the patient's right-hand side. Patient's right, patient's left. So we have the liver in the foreground, the forefield, the four-chamber heart here in the midfield, and then off to the sides you're going to have your right and your left pleural spaces. Okay, so you can see kind of the lungs on either side, and obviously the heart. And this bright white hyperechoic line that surrounds the heart, that outlines the heart, is the pericardial space. So you'll see fluid dissecting this line, in a case of a hemopericardium. So here's an example. We have our subcostal view, our right ventricle, left atrium, right atrium. We see this hypoechoic or anechoic collection surrounding the heart and really going even kind of in our gravity-dependent, far field here. So that's an example of pericardial effusion. And whether it's pathologic or not is up to your clinical correlation. If it's young, healthy 20-something that smacks their chest on the steering wheel, probably pathologic. If it's a person who just got discharged from the ICU, has a whole bunch of cardiac comorbidities, and may have something already underlying. But you always want to assume it's pathologic before you blow it off completely in the trauma setting. Does that make sense? Yes, sir.
So are you also looking to see if there's any right atrial or right ventricular collapse if you do have your tamponade physiology, or do you just stop?
So yes, but that's next week.
Okay.
So very astute. In the traditional fast, okay, so the fast is originally concocted, and the fast, as we do it in the trauma bay for the quick assessment, you're basically looking for fluid or no fluid. Okay, if they don't have fluid, they're not tamponade physiology. But if they have fluid, there's concern for that, and whether they're in full-blown tamponade versus kind of early tamponade versus not in tamponade, that decision is really going to be made clinically, and your treatment in the trauma patient, is going to progress based on the binary presence or absence of fluid. Essentially, we had a patient, Sandy and I had it a few years back, where we actually watched the tamponade progress in the trauma bay. The patient had an injury to the chest, penetrating injury. They had fluid around the heart. Pressures were fine initially, some fluid, kind of early bowing like you're talking about. And as we were waiting for the trauma attending to get there, kind of get on the same page with the team who was already working up the patient, we could watch that accumulate, watch it cause the hemodynamic effects in the heart. So, but we knew the disposition even before they, started to crumb. They're going to the OR. They're getting that drained. So, but yeah, stay tuned for next week. All right. So, what do we call positive? What do we call negative? Right. So, any free fluid in any of the windows is a positive exam. Okay. And theoretically, with bedside ultrasound, you get the minimum number of pictures you need to answer your clinical question. Right. So, my clinical question is, hey, they're unstable. Why? Or they were injured. Is there free fluid here? Yes or no? So if there's free fluid in the right upper quadrant, theoretically, you don't need to do the rest of the belly. Okay. Now we do it for completeness sake, kind of get a visual estimate for how much and kind of quantify the fluid there. But theoretically, once they have a positive right upper quadrant or a pelvis or left upper quadrant, whatever, you got your answer. Okay. You're moving on. Same thing with the pericardial space. All right. When you can't adequately visualize all the windows, okay, it's an indeterminate. So you have to have, basically any one of them to be positive. You have to have all of them negative to call it a negative fast. And when you can't really rule any one of them out, you say, we don't know for sure. We couldn't see it officially. And this really becomes the case in the pelvis, right? If you have a decompressed bladder, it's sometimes hard to see that pelvis. And let's say you had a big, abdominal injury on a full bladder, and you had a traumatic, bladder rupture, right? So the bladder is decompressed. Your air-filled intestines are floating on top of all that, free fluid and kind of obscure your visualization of the pelvis. You may not see small amounts of free fluid in the pelvis, right? So in that case, you would want to say this is an indeterminate, because we just didn't adequately visualize that pelvis, okay? If you see a full bladder and you can see kind of the superior margins of that, great. That's adequate. But if you can't, call it indeterminate. Now, the question comes up is how much blood do you need, or how much fluid, I guess, do you need to have a positive fast? Okay, so this is a study done, I forget when, but basically, if you roll the patient on the right, you only really needed about 100 cc's of fluid to detect it on ultrasound, so not very much. Okay. That being said, for the most part, patients who are lying in the supine position, being scanned as we scan trauma patients in the trauma bay, roughly about that 500 to 600 cc's of fluid mark is the magic number for when a fast exam becomes positive, right? And if you marry that up with the classification of shock, from ATLS, you're talking about someone who may not even be outside of stage 1 shock, right? So you may not have a ton of hemodynamic instability before you see a positive fast exam. Okay. In fact, if you're hemodynamically unstable, you probably got a significant amount of fluid that you're going to discover in their fast. Okay. And this is certainly the case that we've seen. We've had patients who are stable and had a positive fast. Okay. It's just because they hadn't gotten beyond really stage 1 or stage 2 of their shock classification. All right. Questions about this so far? So in the time remaining, I have about 5 cases of unique examples, of the FAST exam. So we'll just kind of walk through these cases, kind of talk through them, and answer kind of questions that come up. All right. So this is case number 1. So this is a young female involved in a trauma. I don't remember what it was, and we're obviously looking at the sagittal view of the pelvis. Okay. So here is a live clip. Does anybody want to take a stab, besides the fact that it's really shaky, which I don't know why? Anyone want to take a stab at what they see? And if no one wants to volunteer, I'll call on somebody.
I feel like I see a little bit, like a triangle of free fluid on the left side of the screen, the left of the bladder, the superior bit.
Where? Right over here?
Yeah, right there.
Okay.
What's the one mass-like thing about the bladder? I mean, there's fluid in just about the superior part of the bladder, but then there is a huge hematoma.
Yeah. So basically, so we have a young woman who's traumatized, right? So things that are normally supposed to be there are bladder and uterus and intestines, right? So we have our bladder. We have our uterus, right there, and we have our intestines. And there's something else, big echogenic mass. with just kind of some anechoic stuff surrounding it. So you're right. This is a big old pelvic hematoma. Okay, so not all things that are, or not all fluid in the belly is black, right? We traditionally say fluid is anechoic, which it is, okay? But fluid that's blood tends to do something called coagulating, right? Coagulated blood tends to have an echogenic, appearance. So here's a clot in the pelvis, and so it's something you got to watch out for because it's really easy to scan past that quickly and be like, oh, I didn't see anything black, so it's a negative exam. You got to keep in mind that initially the fluid's gonna be black. Within minutes, it's going to turn echogenic, and then over the course of a couple days, it's going to kind of liquefy again. But we're not seeing them at this 24, 48-hour mark. We're usually seeing them with the 5, 10, 15, 20-minute mark, right? So it's very common to see echogenic fluid in the pelvis. So here's a patient who is shot, and you can obviously see a lot of air in the intestines. You see the bladder over here, and this snow globe of stuff in the belly. Okay, and that's just the echogenic material, in their belly. Now, could I tell you if this is stomach contents versus blood? No, I couldn't tell you that. But it really doesn't matter. You're not supposed to have that when you're shot in the belly.
Why is there such movement?
Patient's getting CPR. They're not doing well.
It's always remarkable.
This one's a little more subtle, okay? The one I just showed you was pretty obvious, but this one's more subtle. So here's the sag pelvis. Here's the bladder, pretty small. This is all just kind of that dirty shadowing of the intestines. This is kind of this amorphous, echogenic, not shadowing material, which is a pelvic clot, pelvic hematoma. Does that make sense? Okay. The more you see this, the more you'll pick up on it as you're scanning past it. But when you're first starting out, be very careful, and meticulous. Say, hey, you know what? There's no echogenic material that shouldn't be there. All right, case number 2. I don't know. This is a video. This is a patient. Let's make something up. They fell. They fell landing on their left side, and we're doing the left upper quadrant view. What do you guys see?
Inside the spleen itself.
The what?
Inside the spleen itself, there's
something there
parasitic
inside.
inside the spleen itself.
Inside or outside? Outside? Right.
Spleen and liver.
Right here?
No,
Right
under.
here?
No. Under. That under. Is this that? Or no?
Right. So kidney
Oh.
and spleen, right?
Yeah.
So now we're looking at kind of the splenorenal fossa here. We don't really see the diaphragm terribly well.
On top of the spleen, there's this white vascular.
There's something
Right
else
here?
over there.
Yeah.
Yeah.
Yeah, so that's the pathologic part. You guys see that?
What about that under? So there's
That's fine.
nothing there? That's fine?
That's
Okay.
normal. So very good. So this is a subcapsular hematoma, right? So here's an abnormal echogenic material that's not supposed to be there. It's contained as well, right? It doesn't really spill out and kind of interdigitate with all the intestines around it. It's actually contained. You can see it kind of in that semi-crescent shape. And this is something that's not uncommon to happen in the spleen. So you can have like a splenic laceration that doesn't disrupt the capsule and bleed into that subcapsular space and kind of expand that subcapsular space. And only when that capsule ruptures, then does it kind of spill out into the peritoneal cavity. So if we stop that and kind of draw some lines here, there's the spleen, okay? There's that capsule, and this is the hematoma right there. So this is actually something that's not uncommon, that's pretty easy to pass over in the left upper quadrant. So the question is subcapsular versus pericapsular hematoma. Sometimes it's hard to say, right? So indicators that would be a subcapsular is if you see that capsule. Okay, so if you scan down to the southern pole versus the northern pole of that spleen and see kind of capsules surrounding your hematoma, or is fluid spilling out elsewhere? Okay, so here fluid's kind of interdigitating with things, kind of spilling out in a non-contained manner. As a pericapsular hematoma, right? So fluid will take the shape of the container that it's in, right? So I have a cup, I have my drink. If I were to ultrasound this, I would see fluid in a shape that was resemblant of the cup, right? So when you put fluid in a container, a bladder, a gallbladder, a capsule, it's going to conform to the shape of that container. Whereas if it's just spilled out in the intestines, it's going to kind of interdigitate in between all the different things. So if I spilled my Coke on the floor, it's going to go in all the little cracks on the floor. It's going to go up against the podium. It's not really going to take any shape because there's nothing really to kind of contain it. Same thing in the belly. This fluid is going to take, I guess, the shape of the broader belly, but kind of get in and out of all the little cracks and crevices. And you'll see that, some people call it little triangles, just kind of this amorphous shape of fluid in the abdomen. Does that make sense? All right, case number 3. Another left foot quadrant. So we'll make it up. Some dude was driving his car and got T-boned on the left side. What do you guys think? Let's see, is this a video clip? So again, think through normal, think through landmarks, walk yourself through it, and just decide what's not consistent with normal.
So the whole spleen is broken.
Yeah, it looks really weird. So, Dan, you want to point to the kidney? Good. And where's the spleen? Yeah, what do you think about that spleen's architecture?
It's not like your normal homogeneous appearance. It's got some anechoic areas.
Yeah, so you're right. It's
Up on the under the diaphragm, right? Kind of there. It's a little.
Broken.
So it's not. It doesn't have that traditional homogeneous appearance, mid-level echo texture of the spleen or the liver. So when you run across this is highly concerning for a splenic laceration, right? So certainly ultrasound can detect solid organ injuries. Not the most sensitive, modality to image these things, at least with 2D grayscale, non-contrasted. But if you see a disruption in the normal architecture of your kidney, of your spleen, of your liver, it should raise flags in your mind of, hey, you know what? I bet you there's an injury to this organ. And actually, if you marry it up with the CAT scans, the injury pattern that you see here marries up pretty well. I mean, we've had examples where I couldn't find the picture this morning, but a liver with just this nasty injury through it. And you pull up the CT scan, same thing there. I mean, it makes sense. You're imaging the same organ structure, so you can see it. You just got to keep your mind attuned to that. Now, this is beyond the scope of today, but if there's an emerging body of literature about using contrast-enhanced ultrasound to detect solid organ injuries, and the test characteristics are significantly better for obvious reasons, when you enhance it with contrast. And so if you go to some of the national ultrasound meetings, you may hear about that. But for the purposes of the traditional FAST exam, non-contrasted 2D grayscale ultrasound, if you see a disrupted architecture, you should be concerned about that. That is your injury.
Yeah, the evidence is that the worse it is, the more likely we are to see it. So if it's like a grade 1 or 2, you probably won't see it. So if you're seeing it, it's probably a grade 3 or 4 injury. So it's usually really significant.
So, we talked about most of this, but basically it appears as a hyperechoic area or a disorganized architecture. Okay, and it really takes seeing a bunch to really start recognizing it. But once you start seeing it, you're like, that doesn't look right. Here's an example of fluid around the liver, okay, or just a destroyed architecture. Okay, so this is fluid around. There's injury to the organ itself. All right, 2 more cases. That pointer. Who was here last week? You can't talk. All right. So we have, let's just say, 50-some-odd-year-old restrained driver, front end head-on collision, belly tenderness.
Diaphragm rupture.
Why?
I don't see diaphragm, see the lung shadows
All right.
on top of it.
You're onto the right thing, but got the wrong diagnosis. So, here. I'm not even going to try. I'll hit you in the head if I do. So, show me the liver. It should be that one that's marked red, I think. So there's the liver, so right upper quadrant,
So
and then walk me through what you're seeing and what you think.
So the lung is coming
I see the
down.
lung shot. See here,
Mhm.
lines. I should see a diaphragm like that. I
Okay.
don't see that.
That should be out here.
Yeah.
So that's air for sure. Is it lung?
Not necessarily.
I mean, should
Air.
lung be in
Air.
front of the liver in that way?
No.
No.
That's why I said
So what would be in front of the liver?
Bowel.
fear and that.
Yeah, exactly. I mean, you can get loops of bowel, but it's very uncommon to get a loop of bowel in front of the liver in that potential peritoneal space. But when you see the lack of an organ because you just got air shadowing down over it where air ought not to be, that's highly concerning, especially if you're scanning the least gravity dependent area for free air in the abdomen.
So what
Right.
are you seeing? Just the peritoneum?
Yeah, so this is free air here. So free air basically will shadow things behind it. Okay, so you're going to lose your architecture that you see behind it. You're going to have an enhanced peritoneal stripe, so you can see kind of a really prominent peritoneal stripe, and it's going to settle in the least gravity dependent area, right? So if you were to roll the patient onto their side, okay, this air collection is going to move now onto the side, and you'll be able to see the liver better, okay? Or, for example, if you did a Trendelenburg versus reverse Trendelenburg, you'll see that air moving around, okay? So when you see something like this, you got to be worried about like a hollow viscous injury. Okay, do they have a bowel rupture from their trauma? So, all right. So free air in the abdomen. Okay. So air is the enemy of ultrasound. Shows up as an hyperechoic line or enhanced peritoneal stripe and has posterior reverberation artifact. These are just common things that we know to be true about scanning air. Okay. It normally exists within the bowel. Okay. It's not uncommon to see air in the belly. Okay. But generally, that's not in the least gravity-dependent area, okay? And what free air, the difference between contained air in the bowel versus free air is the contained air in the intestines will actually peristall. So you'll be able to watch it and see kind of that kind of moving back and forth. Whereas free air, there'll be no peristalsis. It's not in anything. It's not peristalsing, right? And like Bob says, always be aware of air in the wrong place. Okay, so if you see this hyperechoic with reverberation somewhere where it ought not to be, whether it's intraparenchymal or extraparenchymal, in the peritoneal space, in the mediastinum, whatever, air in the wrong place is always bad. Okay, so beware of that. So here's that free air kind of shadowing over that liver tip. And you're right. The lung is up here, but it normally will stop kind of up at the diaphragm. So. Right, so this is an article that was published in 2007 about recognizing pneumoperitoneum, published by our own Dr. Bob Jones. So it's actually in the literature. And last case, okay, we'll wrap things up with this one in the few minutes that we have left. Again, we'll make it up. This is a right upper quadrant view. Let's say a 45-year-old woman was walking her dog, minding her business, and got hit by a motorcycle. I don't know. Make it fine. She got hit on the right side. She got right-sided abdominal pain. What do you guys see? Stuff.
Do we have a dynamic?
I don't believe so, because the next one has an arrow on it.
No, I don't
We
know if
look at
that's
the Morrison's pouch, and there is a black shadow in the just right to the right side. I mean,
there's different stuff there.
this.
No,
I
is
mean,
the kidney
this is
intact?
the kidney.
That's
Is
kidney.
it intact?
That's the liver.
Mm-hmm.
I don't know. This is.
Yeah, you see that the kidney doesn't look like nice and smooth. And
Yeah, and you can have that as you get older.
Kidney disease.
Oh,
So this is what we're looking at, right? This little space, this echogenic material is between the kidney and the liver. Okay, and this is an example of nephrogenic fat. Okay, so you brought it up earlier. As we get older, it's certainly, and I probably should have made this stem like a 70-year-old woman who got hit with a motorcycle. But as we get older, we can have, basically fat collecting around the liver. Okay, and it can be one of the pitfalls for calling a false positive, saying, "Hey, I got something between the liver and the kidney." Keep in mind that it could be just fat surrounding the liver. So you're looking for other things. Okay, you're gonna look and see if there's little wedges of black here and there. If you got fluid that's dissecting in areas. You're also gonna look and see if you have basically this reflection of the posterior peritoneum. Okay, because the fat should be between that and the kidney. But just be aware, we can develop fat around our kidneys. All right. So just kind of recap, we're kind of out of time here. We talked a little bit about the role of fast in trauma. Okay, in unstable patients and penetrating patients, hugely useful. In blunt stable patients, there's a little bit more controversy. Metro tends to, not necessarily do as much fast in blunt stable patients, and proceed to CT. But other institutions where you guys may go and train or work may be a little bit more liberal in the use of the fast in this blunt stable. Okay. We talked about the basic windows, the 4 basic windows, and talk about some pearls and pitfalls and unique things we may find in positive and negative fast exams. Okay, so with that said, this wraps up the first part. Next week we will talk about the heart. Okay, the different things that you can detect on the cardiac views for the fast exam. Followed by the third week should be the lungs in the thoracic area. Questions? No? Thank you all for coming.